Good afternoon, everyone. My name is Adam, and I'll be your moderator. Dr. Dan Butterman is our speaker today. If you've attended a previous webinar with us, you may have noticed that our in-webinar console has changed. I'd like to highlight some features that will enhance your viewing experience. If at any point you do have a question, please feel free to type it into the box labeled Have a Question, and we'll conduct live Q&A at the end of the webinar. And if you'd like to talk with other attendees, navigate to your control panel at the bottom of your screen and click the chat icon. And lastly, Dentsply Sirona is sponsoring today's webinar. Dr. Butterman, take it away.
Thanks, Adam. I appreciate that. So firstly, I'm not able to see the chat, so I've asked Adam just to interrupt me. If you guys have questions as we're going through here, just type them in. So we'll certainly have a Q&A at the end, but feel free to ask things as they come about. And I'm not able to see you, and fortunately, you're not able to see me either because I'm wearing scrubs, and it was like a huge surgical day today. So like I look like I just came out of battle. So it's probably a win all the way around. But just a couple things about me. I graduated from Baltimore College of Dental Surgery quite some time ago, as you can see. I did my implant training with Carl Misch, who was a phenomenal instructor. It was a huge loss when we lost him several years ago. Aside from my credentials and such, probably the biggest things that you need to know about me is that I do clinical dentistry typically 3.5 days a week. I'm in Centennial, Colorado. I'm just outside of Littleton, Colorado. So I've been doing that for about 28 years. And then on top of that, I teach for CDocs, which means that normally Wednesday night, I'll fly out to Charlotte or Scottsdale, and I'll do CEREC training. All the different levels of CEREC training in Scottsdale or Charlotte. Beyond those things, in all of my free time, I do a tremendous amount of beta testing, mostly for Dentsply Sirona, but some of the other manufacturers as well, which means that I have access to hardware, software, materials, quite a bit in advance. And my job is to kind of find some of the issues with those things. And I work literally daily with engineers in Bensheim and in Sweden on the implant side, just to make sure that everything works great when you guys get them, which happens a lot of the time, not all the time. You have my QR code that's showing up, so please feel free to scan that, and that will just I'm told that will put my contact into your phone. Of course, it could bring you to some weird site, and I just don't know because I've never actually scanned it. But feel free to reach out and email me if you have questions that we don't get to during this presentation. So I want to spend time not necessarily talking about tools, because tools are important, and I really like the saying that a good tool improves the way you work, but a great tool improves the way you think. And I would say that during the course of my practice, things have changed dramatically, and the dramatic change has been somewhat tool-based. But more what I want to talk about today is workflows, and we're going to cover all of these different pieces of equipment, but we're also going to talk about workflows and how they come into play, because a piece of equipment is just that if you can't put it into practice for your day-to-day. As we look about equipment, there's been lots of really good pieces of equipment. There's been lots of things that during my life have been very helpful, and these were mainstream. But I think looking at these pictures, all of us would agree that they have become obsolete. I would argue that the same is true for film. Intraoral radiographs with film, I would imagine that of all the people that have logged in and are viewing this webinar today, probably the majority of you have never actually picked up a packet of film and handled it at all. But I used to have a dark room in my office, and that was our workflow for it. But digital sensors sort of moved us past that. Even something like this that may not be film, but just taken with a full series of x-rays with digital intraoral imaging, I would argue that this is obsolete as well. This has gone away for me just as film has gone away. And when I look at a full series of x-rays like that, it like makes me itchy. I mean, like, I don't even know what I'm looking at anymore. I don't even know how to diagnose this stuff. So much so that when a patient comes to me with a 2D full series of images, I just ask them if I can take a CBCT scan, just because I have so much more information. And putting that up in front of your patients versus something like this is a very different experience. When a patient sits in my operatory and we take our imaging, that's what they see, and that's their first introduction to me. And I think that there's just so much more data that we can get out of this that it really has been a game changer. The Axios is the CBCT full arch scan that I use and I utilize in my practice. And I'll kind of talk about this because it's not just the image, it's how it actually fits in with the full workflow. And that's important. If you haven't seen it before, this is just the scanner in my office. The cool thing about it is it looks really techy. It looks cool. There are lights, centering the patient with it. It's a no-brainer. Assistants have no trouble. There's laser beams that help you line up the patient for midline and proper height position. It's fully automated. There's touch panels. So there's really no confusion as to what size image that you want to use for it, whether you're doing a high-dose scan or a low-dose scan. Anything that you'd like is just simple through that control panel. So that's the other thing that's super important, is that you're going to be delegating these images to your team members. If it's not easy to use, then they're going to struggle with it. I'd say probably the Axios CBCT scanner is probably the most user-friendly one that I've seen on the market. The cool thing about it is you can choose your field of view. So, if I'm just looking at endo and I'm trying to find canals and I want to, or maybe looking for a root fracture, we can do a smaller 5 by 5.5 centimeter view. If I have a patient with sinus pathology, we want to look at TMJ, we're looking at airway, those kind of things, then I can bump it up to a 17 by 13 larger field of view. Probably my most common field of view that I use is an 11 by 10. And that's going to show me both arches. It's going to show me the airway and pretty much most of the TMJ, depending on the size of the patient. And one of the things that I figured out, and the reason that I really, I guess I want to say hate, but hate probably isn't a strong enough word when I refer to 2D images. I feel like you can't diagnose what you can't see, and certainly you can't treat what you don't diagnose. And I think that some of you listening, those that have 3D CBCT imaging in your office, I would imagine that you're all nodding your heads right now saying, I know, like I can't believe how much stuff that I see on a 3D image that I never even knew was there on a 2D image. So that kind of stuff is huge. These are the kind of things that happen in my office every day. This patient has a hole in their tooth. They have no pain, and they don't really understand the urgency of why they need to fix it. We can see the caries on the 2D image, but what kind of a conversation are you going to have with your patient? That's very different than when we do a scan. And here we can see that the caries have infiltrated into the canal. We've got an abscess. That abscess has blown through the maxillary sinus wall, and now this patient has a mixed sinus infection associated with their tooth. So that's a very different conversation with this x-ray versus my PA, and I'm going to handle this, I'm going to treat this clinically very different as well, and you just wouldn't know. With a 2D image, you just would have no idea that that's even out there. This was a patient that came to me not too long ago. She was having pain on chewing on tooth number 18, and she was referred to an endodontist. The endodontist had her scheduled to retreat the root canal. It's not wrong because you look at that image and she has pain when you bite down, and there's a radiolucency on that distal root. And so I don't think that it's a big misstep for the endodontist to say, yeah, we probably should retreat that. It looks like it's failing on the distal. But when you look at it closer, because if I take a CBCT image, what looks like that dark radiolucency isn't an abscess, it's actually just the mandibular canal superimposed on top of the root of the tooth. And those kind of things you would have no idea. So why was she having pain on chewing? Well, she had a root fracture and she had an abscess. She had a lateral abscess beside that tooth. We can kind of make out where that fracture sits as we slice through this axially, and you can see how big that infection is. So the sad thing is this patient would have gone through and had the root canal retreated, and there is like zero chance that was going to get better. That tooth needs to come out, and it saves everybody a lot of time and aggravation to make a proper diagnosis. This patient came into me for a crown. That was the plan. He was having pain on chewing on number 2. We can kind of see, sorry for the poor intraoral image, but we can see a fracture line running through the tooth of his tooth, but the bone looks funky around here. Things don't look right. And so rather than just doing a crown on this tooth, which really had no restorative material in it, we want to take a CBCT scan. Because not only was it was fractured through and through, so much so that there was zero chance of saving this tooth. So this patient, you have a crown done on it, and now all of a sudden they're still having symptoms, they're still having pain. again, it's a bad situation for everybody involved. So we want to make sure that we have the ability to diagnose. Just one last case. To a lot of you guys and me as well, when this patient came in with some pain on that canine, this looks like a class 5 lesion. We're going to do a composite for this patient. When she was having pain, well, maybe it's really deep. Maybe this is going to be endo. But everything changes with a scan. We've got internal resorption. We've got a lot going on with this, so much so that this is no longer a filling, and the patient is going to lose the tooth. Now, I guess that's not exactly true, because I did fill it. I just happened to fill it with titanium instead of composite. But kidding aside, that's the kind of thing that gets you out of trouble instead of into trouble, because you jump in with your eyes half closed on a 2D image, and we just don't know that it's there. So in my practice, I consider CBCT one of those 3 pieces of equipment that I just have to have. These are the things. I need it for what I do in dentistry. I don't do a lot of sleep, but just even doing scans where we can talk to patients and we can kind of visualize what their airway looks like and if they're having issues with their airway in just a few seconds. And this is just my normal diagnostic scan that I'm using for my new patient exam. And we're talking about teeth, but it's really, really nice to be able to see these heavily constricted airways and have a conversation and say, hey, I know we're looking at your teeth, but have you noticed that you've been snoring a lot, or wake up and you feel like you're tired and haven't slept? And most of the time when I bring this up, they're like, oh my gosh, this is exactly, my wife just doesn't even sleep in the same room with me, or I'm always tired. And, it's just a conversation opener. And you can really save lives with this kind of stuff. You can change people's lives. And these are questions you wouldn't ask if you just didn't see it, if you didn't know it. And this just is on every single routine scan that I do. We can see this. So the next, I would say, piece of equipment that I can't live without, because we've got our CBCT image. All of my workflows that we're going to talk about restoring implants. All of my workflows that I'm going to talk about are going to really center around imaging. They're going to center around imaging with Axios and now Primescan, and then they're going to move into manufacture. And the thing that I'm going to use for manufacture, and I have multiple things that I use for manufacture, but we're going to focus on here is the new Primeprint. And I want to spend some information with that. Primescan, I spent quite some time beta testing that. This is just a typical scan on a patient. Those of you that have done it, you know how easy and quick and accurate it is to get these images. Primeprint, which I'll talk about in a little bit, I've been using for almost a year. So I have quite a bit of experience in beta testing that. But if we look at the Primescan, and I think, there's so many intraoral scanners on the market nowadays, and quite honestly, most of them are pretty good. But when we start looking at implant dentistry, the accuracy is what's key. And it's, you can get a really nice picture, but we have to know how accurate it is. When I say accuracy, it's really a combination of both trueness and precision. Trueness meaning how similar is what you scan to the actual object. How alike are those two? Precision is, okay, well, you got it to look alike one time. Are you going to be able to get it to look alike every single time? So that precision and trueness come into play for accuracy. And there have been some great studies that have come out and comparing lots of different scanners. And I won't bore you with all the numbers, but really the Primescan at the time of the study, and really things are quite similar now, it had the highest percent of trueness and precision. Now, granted, a lot of scanners did quite well, but when we're dealing with the most accurate model you can possibly make, then these numbers become important, because with teeth, you can be off by a little bit. And let's be honest, you can be off with your scanning by a fair amount, but teeth have PDLs, they're going to move around a little bit, and we're just not going to notice that. When we talk about implants, especially as we start to move into full arch implant cases, these are kind of things that if you want it to fit passively, the error can't be greater than 30 microns. So we really, really need to get very, very precise with this. And we're kind of at that point now. We're finally at that point with Primescan, where not only can we get it that accurate, but the precision is there as well. That meaning that we can get it that accurate quite often. You can see the long bars on some of these other scanners, because it doesn't help you if you get there once or twice. You need to get there every single time. So we've talked about Axios a little bit. We've talked about Primescan a little bit, the accuracy of that. everything kind of changed in my office when we added 3D printing. And it's not just adding 3D printing, because I've been doing that for quite a long time, but it's actually adding 3D printing that is convenient, that's not messy, and that's safe. And I think that's what's really been a game changer. Because, if I ask you guys, some of you may say, okay, film's dead, I get it. Maybe 2D images, yeah, that's going away. I get where for the most part we're going to need CBCT. Physical impressions, I would argue physical impressions have been dead for quite some time because of all the great intraoral scanners, but you kind of don't want to throw your stone away. A lot of you are kind of like, no, stone is just more accurate. That's the gold standard. This is just one study, and it was done by Sprint Ray. So you have to take that with a grain of salt. But really, there are a number of studies that have come out and repeated that we are able to scan and print a model with better accuracy than you can do with a physical model that's poured in stone. So I would argue that, like those other technologies that have become obsolete, stone's one of those things, stone and plaster. This stuff just doesn't, it's kind of disgusting if you think about it. You're choking your patient with your impression, you're pouring that up in stone, your assistants are grinding on this, making a mess, hitting something's busting off of it. This is just not the way to practice dentistry, in my opinion. And so much so that when I was preparing another lecture, I asked my assistant, I said, hey, I just want to take, I went into it was my wet lab. It's now where I keep my printers. And I said, I want to take a picture of my model trimmer and my stone mixer and all of that. And I'm like, where is it? I couldn't find it. And so my assistant Bree starts laughing at me, and she said, we haven't used it in forever. And she took me down to the basement, under a counter in the basement, and I found it and took a picture of it. So just like my dark room back in the day, which is ridiculous even thinking about having one now, so is a wet lab. These kind of things, those days are gone. Assistants, team members, patients, it's just messy. It's not something anybody enjoys, and it's just not necessary. We used to think it was because we thought that was the most accurate, but it's certainly not there. We used to also insist on it because we thought it was the most convenient. And it certainly is not that anymore. So let me talk about Primeprint just a little bit, and then we'll get into some of the implant workflows. And please reach out with questions as we go through here, because I know this is new for a lot of you guys. The printer itself, so you're looking at two boxes, the printer and the processing. So there's multiple resin cartridges. You choose the resin that you want for the device you want to make, and you're going to put it into the resin carrier. Basically, we call this a material unit. So the resin cartridge with the resin vat basically is a material unit. You put it in, the scanner knows what it is. This is a Primeprint box, and this is why it's so clean, because the build platform is contained within that Primeprint box. You put it in, the software knows, hey, this one is for models, or this one is for splints, and there is no cross-contamination with it. When you send a job to print, that resin cartridge opens up, and it doesn't fill everything entirely, it just puts enough resin, and it knows how much it's going to need for the print job. You're going to print your print, and here's where it gets really interesting, is that once it's printed, this robotic arm comes and it places it back into that self-contained print box. Your assistant or you will then just pull that box out of there and drop it into the PPU or post-processing unit, never touching resin, never smelling resin. A robotic arm will take it out of that box and put it into the first wash unit. So it'll do its pre-wash, and then it will do its final wash. These wash containers, again, are specific to the type of resin that we use, no cross-contamination. I have separate wash tanks for all the different units. Then it's properly dried, and from here it goes into the curing unit, and it's cured depending on that material, thickness of the material, all of those factors come into play, and then it goes back into that box. So when the print job is done, you simply remove it from that box, and it's ready to go. So the first time you come in contact with anything that you print, it's already been fully processed. And that's super, super important, because really what we're talking about when we're looking at all of this stuff, really what we're talking about, and I'll just kind of walk you through my model phase, if it's going to go in somebody's mouth, and you're going to print something, not for a model, but if we're going to print a surgical guide and we're going to print a splint for a patient, for example, or even temporaries, if it's going to go into a patient's mouth, how clean is that object? How healthy, how safe is that object? And if you think about it, our resins are FDA approved, and our resins are designed to go into a patient's mouth. But what about the processing part of that? What about the PPU, the processing part? Because if you think about your composite workflow, let's forget about 3D printing. If you take a composite resin and you put it in somebody's tooth and you cure it with a light, you know that that last layer of composite doesn't fully cure. If you cement a crown and you use a resin cement, that last outer bit of composite resin doesn't cure because of an oxygen inhibition layer. We know that because oxygen prevents that cure. Well, in a patient's mouth, you can put glycerin on something, you can block out oxygen. But when you guys are 3D printing and you have an object, how are you dealing with that oxygen inhibition layer? And the answer is you're not. That's why one of the cool features I didn't show in that video, but one of the cool features of the Primeprint is that it is not cured in an oxygen environment. There's a nitrogen tank, so all of the prints are cured in a nitrogen-rich environment, meaning there is no oxygen inhibition layer, and we have a much safer product. I think that medical grade is super important when we start talking about the things that we're using in patients' mouths. You do it with an autoclave. You make sure your instruments are properly treated and sterilized for safety. We need to start thinking about doing that with printing as well. So here's my workflow. Patient needs bleaching trays. This particular patient needed bleaching trays. Some of you would pull out alginate, and then you're starting to pour it up, and you're doing all of that, which again is disgusting to me, and it's too time sensitive. So I'm going to pull out my Primescan, and these icons are brand new. If you have a CEREC, you don't have these icons on your machine. This is unlocked with the printer. I can choose between a solid model and a working model. For a bleaching tray, I just want a solid model. I'll show you what a working model looks like in a minute. We'll just click on the upper jaw and the lower jaw, and the software now knows these are going to be solid models, what the material that we're going to be printing, and it's going to be going to the Primeprint. You'll do your scan in the normal fashion, so we just have the upper jaw, and as soon as we go to design, the software, as quickly as you just saw, that was live, will convert this into a solid printable model with a hollowed out base, and it's ready to go. So one of the cumbersome things is that you scan with your Primescan or whatever you're using for imaging, and okay, great, well, I've got the scan. How do I get it print ready for models? And that's now built into the chairside software with CEREC. Is with a solid model, we have it ready to go, and this is something that can be printed. You know, you can get kind of silly with these things, or it's a little bit helpful if you're printing a lot of models. You can just you can label it. So these were made for bleaching trays. You can put the patient's name, and you can just kind of drag it and drop it onto there, whatever you like, and then that will be printed as well. Once it's printed, those of you with a Primescan or Omnicam that are milling in your office, you know your normal workflow would be to send it to the mill. Here, I'm just going to send it to the CAM software. So CAM software is basically our printer version of the software. You can also use the same software for milling and manufacturing for any restoration, but there's a fast forward button. And the way I get it ready to print is I simply open the CAM software. Those models are in there because I just sent them there from my Primescan, and I hit fast forward and it's ready to go. So what you're looking at are print ready models. You can choose how the supports are applied, the position of these models, and it's quite simple. It's all automated, meaning that the software, you tell the software, do you want highest quality? And it'll angle them appropriately. It'll put the right supports on. Do you want it to be the lowest area? So you can, if you want it to be this fastest speed, you can drop them down so they're flat on the base if you want faster speed, or if you want to take up the least amount of room on the build plate, you can do all of those things, and the software will just kind of set that up and be ready to go. So this is what a printed model looks like. They're just supports that you break off, and it's hollowed out and ready to go. And again, you can do that with solid models. On my bigger cases, when I'm doing anterior restorations and I want to contour, stain, and glaze them, you have the ability to do either ditched models, meaning that the software will just cut a groove around the die so that you can actually seat it. The tissue's not in the way to seat it on the model if you're trying restoration on, or you can even do something with removable dies. So whatever you prefer with that. This would just be an example on the left of a ditched model, and on the right where we have something that you can actually pop in and out. And again, there really is no work involved in doing it. We just select what we would like for that and send it to the printer. So I would argue that those workflows have become so easy and so clean in my office that we could print a model, have it ready to go much faster than most of you could pull out your alginate and be ready to go with a stone model. So it's a big time savings, and it's also less cumbersome. The last thing I just want to talk about a bit, because we'll introduce it with the couple cases that I'm going to show you here, is the new Prime Taper implant. So I'm showing you the AstraTech Implant EV first because I want you to understand that a lot of the features of this have been maintained. So the features that I liked about an Astra EV implant is the deep conical connection. We know that EV deep conical connection. We've got an Axios speed surface, which is going to be quick for integration, and micro threads on the coronal third of the implant that's going to help that tissue and bone stay on the coronal part of the implant. So really nothing's changed with that. And I think, one of the things that I used to always wonder about with implants is, does it really make a difference what the surface is? Titanium's titanium, everything's going to work. Is it really a big deal what is on the surface? And there have been some really good studies that show, yeah, it actually does make quite a bit of a difference. These are three of the most popular surfaces. We have Axios Speed with Astra EV, we have Tyenite with Nobel, and the SL Active for Straumann. And now, granted, if we look at this, this is bone loss that happened, marginal bone loss in the first year versus the 5 years. On a bar chart like this, the Astra looks way better than everybody else. But in all fairness, they're all really good. I mean, these are all premium implants, and really we didn't have a ton of bone loss on any of them. But the thing that's really interesting to look at is it comes back to what I was talking about with trueness and precision before. The spread of how often, so you're going to lose some bone, but some cases with Tyenite and SL Active, some of them were all over the place. So some you lost a little bit of bone, some you lost a lot of bone. What we see with an Axios speed surface is that it's consistent. And that's really important because you want to know that, okay, it's going to be great, but it's not going to be great sometimes, it's going to be great every time. And I think those are things that we do need to look at very, very carefully when we're choosing our cases. So this is the DS Prime Taper implant. I had the huge honor of introducing this in front of many thousands of people at DS World this past September, which was pretty exciting. And so probably the biggest changes, and again, they kept the surface, the Axios speed surface, they kept the micro threads, they kept the EV deep conical connection. The biggest change that they made to it is they added a progressive taper, a much more aggressive thread to it. And that's really been missing with this implant. This is the first Prime Taper implant that was placed in North America. Those are my bragging rights for the rest of my life. And I'll tell you that when you place these things, especially in low bone or immediate extraction cases, those aggressive threads make a huge difference because it kind of, instead of being what we used to have with an Astra EV implant is more of a wood screw, a machine screw. Here we've got more of a wood screw where we can really just grab it to bite and it'll make its way into bone. I did in one of my beta cases, I was doing an immediate molar extraction. And when you do a tooth like this, you take the tooth out and you always want to try and get the implant into the interceptal bone between the two roots. But you know what happens. I mean, you try and do it and you drill everything right, but you've got two big holes sitting next to it, the mesial root and the distal root. So a lot of times the implant just drops in there. But the cool thing about this implant is that thread, once you drill your osteotomy, there's two components to this implant that really help in this situation. So the aggressive threads to get it started, because it's going to cut its way into that osteotomy. But then as we move up to the coronal third of the implant, we've got more of those square threads, and that's going to keep it centered. An aggressive implant all the way from top to bottom, those tend to walk around on you and they can go anywhere. So this is aggressive where it needs it to start cutting in, but it's got basically a self-positioning or self-leveling a screw pitch pattern on it so that it's going to keep it where it's supposed to be. And they're kind of interesting. They're just different to place. Surgical kits, super easy with this. We don't have those big, ridiculous surgical kits that have parts and pieces all over the place to make mistakes with this. And that's really important because your team members need to set this stuff up as well. And if you've got a lot of different components, then it becomes tricky. This is the non-guided kit that I'm showing you. I have the guided kit, but we don't expect that to launch for just another few weeks, if I have my correctly. So you'll be able to purchase the Prime Taper guided kit very, very soon. Drilling protocol, the recipes are simple depending on the diameter of implant that you're going to place. And now they're just referring to them as small, medium, large. Small being 3/6, 4.2 medium and 4.8 or 5.4 large. The connection is the same as the Astra EV, as I mentioned, and you're just going to follow a relatively simple drilling protocol with this. The other thing that's been redesigned, which is pretty nice, is the new driver. There is nothing worse and more embarrassing than picking an implant. Well, let me step back. Trying to get the implant out of the vial and having a hard time engaging it on the driver, and then when you do, having it fall off of the driver. That's like a really, really bad day. So this new driver is really cool because it easily engages the implant and it like snaps in, and you can feel it snap in, and that's not going anywhere. The thread pitch on this allows the implant to be seated 1.5 millimeters per rotation, so it goes in quick. You can see it cutting in really quick. This is an immediate extraction case, and then it just torques out depending on what you have it set at. And then when I want to release that driver from the implant, I physically have to unsnap it. So it's really, really a nice change in my opinion. We've got a much more aggressive implant that can cut its way in, and it's going to stay centered in the osteotomy. And then we have a driver that's just going to be easy to work with. So let's take a look again, because I've just been trying to make these comparisons between analog and digital workflows based on what people were doing. Let's look at an analog implant workflow for somebody missing a couple teeth. What's the first thing that you do? The first thing that you always do on these cases is you take an alginate impression, you get a stone model, because when you're not sure what to do, that's the first thing you always do is you get a model. And then from there, once you have the model, you might send it to a lab, and the lab will do some sort of a diagnostic wax up for you because you want to know where the teeth are going to go. And then you're like, okay, great. Well, now I need to incorporate that into my x-ray. So you'll ask them to make some sort of a scanning appliance with maybe barium sulfate so that your teeth will show up on an x-ray. Now, all of that has taken a couple of weeks maybe for each one of those components, and it's probably cost a couple $100 to even get to that point. Now you have this made, you put it in the patient's mouth, and you take an x-ray, and now finally you know where those teeth are supposed to go. You can relate them to the bone on your CBCT scan, and then you can reach back out to your lab and you can say, okay, can you make me a surgical guide so that my implants go here? So this entire workflow is what a lot of people are doing, and it's just inefficient, quite honestly, because each one of those steps might take a couple weeks and they might cost a couple $100 before you're ever ready to go for surgery. And it's just not necessary anymore. So here's my workflow that I use, and this is probably my go-to workflow almost every day in my practice. So it's going to start with these four things. I need a scan, and when I say a scan, it's going to be an optical scan, which for me, I use my Primescan, and it's going to be a CBCT scan. That will be with my Axios. That's step number one, is get my scan. Next part is going to be plan, and you'll see how easy it is to do that. Typically, I'm either using one of these two planning softwares, CCAT 2.0 or Simplant. And now once you plan it, you're going to need to have your physical guide fabricated. I like to print those. You can certainly mill those on an MCX, MCXL, or Prime Mill, but I much prefer to print those. One of the huge advantages of printing versus milling, other than it being much cleaner, is that you can do multi-unit guides. So I can have multiple guide hole positions in a printed guide versus just a single site in a milled guide. And then finally we place. And having a good implant and having a good guided kit is what allows you to do that. So let's look at it from a different perspective. That's going to be step one. Patient's missing teeth. What do? Well, I'm not going to pull out my alginate and I'm not taking a stone model because I can do an optical scan. I'm not sending it to my lab for a diagnostic wax up because within my CEREC chairside software, I'm going to plan where the restorations are going to go. These are not generic teeth. These are not just shapes of teeth. This will meet with the patient's proper occlusion. These teeth have to go here. They're in proper contact, proper occlusion. From here, I'll pull it into my cone beam software, and it's going to allow me to make a decision of where I want to put my implants in relation to my crowns. If you want to do a screw retain restoration, it's probably not a horrible idea to have your implants parallel and have the screw access hole coming through the central fossa. Can you do that by just eyeballing it up? Some of you might be able to, but for me, I would rather plan it this way. And once I plan it where I want it, then I'll pull it back into my chairside software, and I'm going to design a surgical guide. This is fairly automated, the new surgical guide software that we have in Primescan. And it will basically, the only thing that I really need to do is put viewing windows if I want to. So once I've set this up for my chairside software, as you saw with a model, I can now send this through the CAM software to my Primeprint, and we're ready to go. So this goes into the patient's mouth, and we're ready for surgery. This becomes very, very predictable. We'll look at this case a little bit later, but I'm going to put 2 implants and make a bridge on the left, and then we'll do just a couple individual ones on the right. Surgery predictable. I'm going to use the Prime Taper guided surgical kit, and then from here, a Prime Taper implant goes in. So the cool thing about this workflow that really takes you from A to Z with it is that it's totally integrated. Everything from the optical scan through the CBCT, the planning software. And people always argue about, well, it's a closed system, and I don't know, I kind of want to be able to plug in any of my parts and pieces. I mean, that's fine, I get it. But, you know, in order for it to be seamless, in order for it to be quick and efficient, these are the kind of things that you really need one workflow with one system into place. So let me walk you through Larry really quickly. I don't have actually, like, I don't even have the final restorations for either of these cases because of FDA approval of stuff, but you'll get a pretty good idea with it. So Larry pops off his left front too, is endodontically treated, and he had a crown on top of there. You'll see Larry's not, cosmetics are not a concern for him. But I do this in front of Larry, so I just do an optical scan. I plan what the final crown should look like in front of him, and I say, okay, that's what I'm going to be able to make for you. See that dark triangle? Well, guess what? You're probably still going to have that. We might be able to create the pill a little bit, but he had a diastema, and he just wasn't going to have one, so we get to talk about all these things before surgery. So I'm going to pull his plan into the CEREC software, and I'm going to plan exactly where that implant's going to go. Do I need to graft the case? Is this going to be a screw retain restoration, or is it going to be an abutment and crown? So based on where his bone was, there was no way I can position this implant palatally enough to do a screw retain restoration. Well, that's okay because I know it. Now, certainly we could have done grafting to get there, but I know in advance that when I make his restoration, it's going to be a set abutment and crown because the screw access hole is going to come right through the incisal of that restoration. So we've planned it, and now I'm just going to export this plan back into my CEREC software. And I'll show it to you in video format with the bigger cases, but the software is going to choose where that sleeve height is. It knows where in space that implant is because we just planned it in CCAT 2.0. And then with the click of a button, we have the surgical guide designed. That surgical guide, again, is sent through the CAM software to my Primeprint. And this is what it looks like. The image on the left is still attached to the build platform. My assistant has pulled out that print box container that you saw, and then she's just going to pop it off of the build platform and cut off the supports, and this is ready to be autoclaved and ready to go. Is there any uncured resin up underneath there? Is there that oxygen inhibition layer sitting up underneath it when you cure it, when you process it with any other system? There's not with this. And I mean, quite honestly, if there is, how do you even get it off? Are you grinding up underneath where it's touching teeth? You're probably not doing that. And do you really want to put that in somebody's mouth afterwards? So that nitrogen-rich environment is what's preventing you from having any uncured resin on this. And it's just, that's why they consider it medical grade, quite honestly. So here's Larry. I've just extracted his tooth, and we're good to go. You can see aesthetics are probably not a huge issue for Larry with what he's walking around with. This is the printed guide. You can kind of see the remnants of where those supports are attached to. It's relatively clear, but I still like to put windows in there sometimes just to make sure everything's seated. And if you've milled a surgical guide, you know that sometimes fit can be iffy with it. The fit of this is insanely good. So this is just the guided osteotomy, and you can see that the drills have a sleeve attached to it, meaning that it's a keyless system. I don't have a key that's going to be attached to the guide that I'm popping in and out. The sleeves associated with the drills are what is shrinking the diameter of the guide hole. So I just follow the drilling sequence, and now we have our implant ready to go in. And the deal with Larry, he's kind of like a family friend. The deal with Larry is that he is not going to wear anything removable, and there was no room to make him something like a one-wing Maryland bridge. He's just like, I need to have something in there right away or for my front tooth. And that's where having a really aggressive implant is important, because if I didn't have high insertion torque with this, it was going to be a bad day. So I'm measuring my insertion torque and making sure that we're good in a situation like this. And we were totally fine with Larry, which was fantastic, because he would have probably shot me if I couldn't put a temporary immediately on that implant. So at the time of surgery, I'm doing a scan. So this is just what is a scan looks like immediately at the surgery. I've got a scan post and a scan body on top of there. This happens to be a true abutment scan post, because I wanted to take the restorative platform and move it away from the implant. So we'll do that scan. I'm going to design this, but I'm not designing his permanent restoration. All I'm designing is his provisional. And since it's a provisional, where's the screw access hole coming out of? Well, it's coming out of the incisal, but I don't really care. It's going to be a provisional, and we'll deal with that in the final. I want to encourage that tissue to stay where it's at and not migrate apically. So when I design this, and probably beyond what we can talk about here, but I want to under contour this restoration, aggressively under contour this restoration, so it's not pushing on the tissue. Because if I put it in the tissue blanches, it's going to move apically. I take that same design, and then I design, because I already know where that screw access hole is, I design his separate abutment and crown and just save it. And that's just sitting in my software. Because once he heals up, do I really need to scan him again? I know that the tissue is going to stay where I put it, which I'll show you in a minute. Do I really need to scan him again? I can just come back to this case, and I can just remill this out of a zirconia abutment and maybe an Emax or Tessera, whatever you like, crown on top of it, because the implant's not going to move. It's not like I need to get a new image of that implant. The teeth aren't moving because he has his screw retain provisional. So this is his provisional as I immediately seat it. And you can kind of take a look. I literally just screwed it into place and then just closed it up with composite and took a photo. There is no blanching on the tissue. The tissue is just lightly sitting on top of that. So the goal is, and this is, for me, whenever I place an implant, what I like to do is come back, instead of just take a 2D image, because everything looks pretty good. All anterior implants look pretty good on a 2D image. The question is it sticking out of the buccal plate? And so I feel like legally it's probably a good idea to get a scan of that. But a lot of us don't like to do a CBCT scan because we feel like, well, I don't want to do that as a check film because I'm exposing the patient to radiation. But the low-dose scan with the Axios is nice because it's about the same amount of radiation as the 2D scan. So we can go ahead and capture that. This is how he left, and this is how he returned a few weeks later. And we can see that the tissue, not only didn't it move apically, it actually moved coronally just a little bit, just to bring it back. You can see where it started and where it moved to. So it responds really, really well. So this case I just finished. So when Larry comes back next week, I'm not going to image him. We've already milled out his final restoration and abutment. So it's a simple matter of unscrewing this and torquing the abutment and crown. These are the best cases to do because quite frankly, Larry is he's a walking shade guide. And really anything's going to look okay for him. So these are great cases to first start with because you literally can't make it look worse. Let me introduce you to David. And David is a super cool guy. I show his medical history because he's 85 years old. He came to me through donated dental services. So David, he's so healthy. He drives himself. He's like, his mental faculties are all there. So he's not like your 85-year-old that some of us have coming walking in. He's not taking any medications. He's probably healthier than I am. And he looks great. And his chief complaint is that I just need more teeth. I can't chew well enough. And so what he thought he was going to get was a partial denture. And when I looked at him, I'm like, okay, well, we've got those huge tori in the way. And he also wanted to save what he had left. That was a big concern. He's like, I don't want to remove any more teeth. I just want to add teeth. And I'm like, okay, a partial is just not going to work great for you. Just how would you class that? And with all the tori, and I'm like, it's just not going to work. And he's like, no, it's fine. I totally understand. He's a disabled vet, and he served his country, did so much for us. And so he's like getting up out of the chair saying, I can't really afford to buy meat anyway, so I really don't need to chew that much. And when he said that, it kind of broke my heart, to be honest with you. So I'm like, okay, just sit back down. And so we decided to do an implant plan for him. And Dentsply Sirona was very kind. They donated the implants, and I took care of the rest of it for him. But I just want to really quickly walk you through that workflow. I know I'm running out of time here. So here's how I set it up with David. I just want you to see, literally, this is pretty much live all the way through, and I just did this in front of him. So first thing I'm going to do is do my implant prosthetic planning and positioning. I'm just going to choose all the teeth. The software is going to calculate that for me, and I'm just going to have the opportunity, once it calculates it for me, I can just move him around. I can adjust the occlusion. He's got a full denture up above. The reason I plan to do 2 implants on that left side and then a 4-unit bridge is because it's opposing a full denture. I probably could have put an additional implant in, but I feel like that's going to work pretty good for him. So once I plan it, I'm going to pull that into my CCAT 2.0 software. The software easily lets you map out the nerves so you can see and make sure that it's safe. But again, I'm doing this in front of David. I do this in front of my patients always because I want them to see what I'm seeing and if there's going to be any complications with it. So importing the scan is simply just picking a couple common points on his optical scan, and probably 3 points are enough with it. And then the software is just going to merge all of that data together. So you know you've got an accurate scan. So once you approve it, it's just going to bring all of those teeth in that you designed. So the huge advantage is I know exactly where those crowns are going to be. And David's got a ton of bone, and some of you will be like, well, I don't need a surgical guide. He's got so much bone, you can't miss the bone. Well, sometimes having too much bone is also a problem because the implant could kind of go anywhere, right? And you know, you have too many options almost. So I want the ability to be able to position and move this around in bone so that they're going to be in the right place, that they're going to line up properly with all of his teeth. And if there are going to be some issues, such as maybe needing grafting, which we didn't need for David, I know that immediately. And I can see all of that, and I can get everything totally planned with that. Once I'm happy with my plan and I've set up the implants that I want for it, then I'm just going to pull that back. I'm just going to fast forward this a tad here. I'm just going to fast forward that and bring it into my CEREC software. So here's how it comes into the software. I'm just going to select the patient. All the guide sleeves are in here, and you'll see how difficult it is to make a surgical guide. So this is happening just in real time. I can choose how thick I want the guide, and then I ask the software to calculate it, and then it calculates that guide. I can go through and I can add some windows in here and make this exactly the way that I like, so we can seat this into the patient's mouth. For David, because there was no distal support, I decided to increase the size of the surgical guide. I just wanted to put a couple legs, a couple supports just on the distal here, just so that it wouldn't have any movement to it at all, and it would be able to at least rest on that tissue a bit. So the software lets you easily do that, and I'll fast forward that just a tad. So here's the design. I can trim it up and clean it up just a little bit. And then again, we're in the manufacture phase. I can just export this to the CAM software. So when I export it into the CAM software, it's going to be in there. It's going to be ready to go. I just select a surgical guide. Software already knows this is going to be out of guide material, and I hit fast forward and it's ready to go. And then I simply hit print. So this is printed. This is what it looks like when it comes out of the when it comes out of the printer. It's just self-contained within there. And I think some of you that have had, and I bet a lot of people listening have used 3D printing in their offices, that's real. And I think we tend to have this love-hate relationship with 3D printing. I think we get into it and we think, wow, this is really cool. I love it. And then after a couple of months, you're like, this is really messy and disgusting. I hate it. Because it's really, it is, and it smells bad, and there's stuff dripping over, and you're trying to not get it on your skin. So here's the exposure that my assistant has. And you'll notice she's not wearing gloves. It's just finished printing. She's going to pull out the Primeprint box with the surgical guide in there, and here's how she processes it. And this is all the training I did. I said, hey, Bree, take that box and put it in the PPU, post-processing unit. We've already got the alcohol tanks in there, the isopropyl alcohol, and hit start. That's all the work that really is involved. So there is no chance of touching resin. It's just super clean, and we know that this is going to be medical grade. So it comes out of the printer, and all we need to do is remove those supports, put the sleeves in, and we're ready to go for surgery for David. I did a tissue punch. We had a lot of tissue for him, and I'm sorry I'm going quick. I know I'm running out of time here. Did a tissue punch for David, guided, and really whether I'm placing one implant, as in the previous case, or I'm doing multiple implants, the workflow is exactly the same. I'm going to be guided with my position. Here are all the osteotomies done for David, and implants are going in. We had high insertion torque on all of these implants as they went in. And we have his healing abutments, and this is how David left my office. Just our x-rays, and as I already said, whenever I place an implant, I do like to come back and I like to verify it with a CBCT and make sure that they are where I planned them here. So we can make our bridge on his left side and then a couple freestanding implant crowns on his right side, and he's good to go. This is how he healed. So the next step is, well, how are you going to restore this thing? And one of the new features also that we have available to us comes with on the side of restoration as well. I already mentioned the accuracy of the Primescan because really that used to be a physical impression for me. If you're doing that long a span and I wanted to make sure that everything was going to fit, I always did a physical impression for something like this. But I know that the accuracy is there now. So we have multiple options. So where I did that long span bridge, I'm going to use a brand new scan body called an IOFlow S. The S is for superstructure. It's one piece and it just screws into the implant, and it's a non-index scan body. Because if I'm going to make a screw-retained bridge for him, I would rather it not be indexed. On the other side, I could use traditional IOFlows. I could do this in office. I could use a tie base. I can use a Dentsply Sirona scan post. Any of those options are on the table for me for just a couple crowns. For David, I scan the entire case, and I'm just having the lab make something. And I apologize, it's not back. I was trying to rush it. But it's not back yet. But what I'm making is something called a bridge base. So I've got that long span bridge that we did for him. And, you know, I wouldn't want two abutments. I don't care if it's zirconia that's going on top of it. I want to have a metal superstructure all the way through, and then I can have zirconia on top of it. So that's the point of a bridge base. It's going to be non-indexed, and that's going to be David's restoration. Just in my last minute or two, and I'll just end a minute early, splints are things that I'm doing routinely in my office. We're just exporting these cases. You can design them. There are some new apps. When you get a Primeprint, one of the cool things is you get the full version of in-lab software and in-lab CAM software as well. So you have the option to design lots of different restorations as well, and you can manufacture those splints. And the last thing I'll just mention, also just launched, is something called DS Core. DS Core means that every scan that I do, whether it's an X-ray or whether it's a Primescan, you can now have that immediately sitting up in the cloud. And the cool thing is all of these images are available to me anywhere, which means that I can start looking at this, I can send it, I can download it, I can see it. But more importantly, I can do my workflows cloud-based, or at least some of them now. And they've just begun to launch this. So I have my CBCT scans. I can get my scan. It immediately goes up into the cloud, and I have access to either see this on a viewer or I can send this to anybody. So we're kind of done sending CDs and all of that with CBCT scans on it. I just send them a link, and they now have this, and they've got it ready to go. But one of the new features is a design service that's available from Dentsply Sirona as well. So after I do, and I'll move this along just a bit quicker here, you can manipulate all of your images, rotate them, adjust contrast, but all of my CEREC scans are here as well. So I can open any CEREC scan that I've done, and all the models are going to be here. And I can download this case. If I have a workstation or if I have in-lab software, I can download it. Or I can now click on it, and I'm going to have an order design service. Right now, the only services that are there are splints or temporaries. So you just choose that, you choose the date, and you can place your order from there. This would then come back. So if I chose a splint, I would have in 6 hours the splint design. And once I approve it, it would just be sent directly to the CAM software, and I can print it directly. So I can do all of this from being out of my office. Once a scan has been done, so I was out of town just the other day, my assistant is doing my CEREC scans, and just from wherever I am, I can look at the scan, and I can order that splint from being out of town, and I can send it directly from my printer without ever being in the office. And that's it. A lot of information. I know I went relatively quickly, but there's just so much cool stuff to talk to you about. And they told me I only had an hour or like 50 minutes, and I know I blew past the 50 minutes. But hopefully you can kind of get an idea that it's kind of cool. The workflows have changed so much. I'm going to pull this off and minimize this here so maybe I can see a bit of what you guys are seeing here. So I don't know if there have been any questions. I see nothing. Adam didn't interrupt me once. Maybe just like you guys just logged out and left. I don't know. But do we have any questions, Adam?
Yes, there was actually one in the chat. So the question is, what is the size of the print platform on the Primeprint?
Yeah, I can't tell. Like, I don't remember the number, but if you're trying to compare it, a lot of you are probably familiar with SprintRay and their platforms. So it's a little bit smaller than the SprintRay 95. It's a little bit bigger than the SprintRay 55, meaning that the build platform is dependent very much on the resolution of your print. So if you're trying to do really resolutions that aren't very big, you don't need super accurate prints, then the platform gets really, really big. But if you want the ability, like with the temporary crown, to do something with super high resolution, then you can't have a really big build platform. I'd probably say I can easily get 4 models on that. More than 4 models is probably pushing it a bit.
All right, that was the next question, so you read my mind there. What about the cost for Primeprint?
I can tell you as of the May 4th, Dentsply Sirona has announced that it is, if I make a mistake, I apologize, but the retail recommended price for it is $29,700, so almost $30,000, just under $30,000 for it. And the interesting thing to think about, and that includes just a bunch of stuff, but some of the things that it includes, which you need to consider very carefully, is it includes the full version of in-lab software, and it includes the CAM software as well. So somebody who's thinking very, very carefully might say, hey, wait, so I can just buy digital imaging and not buy any manufacturing, and I can buy a Primeprint, and now all of a sudden I also have access to probably the best, most detailed design software available. And now even just going through digital imaging, you have the ability, because of them including in-lab and CAM, to manufacture, to design and manufacture and send things to the print. So I think because of that and the medical grade features of it, it's pretty good value. I know it's a premium compared to other printers on the market, but with the workflows, medical grade, and the in-lab and CAM software, I think it really makes it worth your while to at least look at it.
Excellent. Well, I think that answered all the questions. We'll end a couple minutes early here tonight, so thank you everyone for your time, and of course thank you to Dr. Butterman for the fantastic presentation. If you enjoyed our webinar, please take a quick 30 seconds or so to complete the short survey that'll pop up on your screen as we end. We did record tonight's webinar, so we'll get that out to you sometime in the next week, or if you simply click the link you did to join this in at least an hour or so, you'll be able to watch the on-demand presentation. That's all I got. I'll give you 2 minutes back in the hour. Thanks, everyone.
Thank you. Take care.